right.
No.
All right. So this was the second PARC retreat, the first virtual retreat. And so I want to thank Mark and Alyssa, for inviting the speakers. It was phenomenal. Anna Landau helped to organize this meeting. I will say that compared to the first meeting, the lack of posters was problematic. I wish that there had been some poster sessions or at least some breakout groups. I miss the food and drink. I think probably everybody does. And so Mark promises that we'll work with Zoom and Grubhub.
Yes, absolutely.
So that the next virtual meeting will have food and drink. So the other thing I want to point out before I say anything about some of the content here is that this is Pain and Addiction Research Center. It's a virtual center. It's not pain or addiction, right? So what we've got some great talks on pain. We got some great talks on addiction. What I'd like to see more of is that interface. How do they interface? How do they work together? All right, so I've got my screen up here. Now I'm trying to advance my slides, so I don't know.
You have to click on the screen first.
At bottom left.
I got it. Okay. So why do we have PARC? Well, as we heard earlier, some substance use disorder patients have pain. By definition, chronic non-cancer pain is undertreated. So as Lawrence showed earlier, there's literally tens of millions of people with undertreated pain. And I would say that the problem of undertreatment of pain, which was, I think, backed up by Stefan as well, is about an order of magnitude greater than the problem of substance abuse, though both are quite serious. We don't know the cause in most patients with chronic non-cancer pain. If we do know the cause, it's a very rare condition. Obviously, we do know the cause in sickle cell anemia. We're getting close to an understanding in migraine. But, as Alan said, the largest single group that we have to deal with is chronic low back pain, and we do not know the cause. The other thing, and I think the main reason for PARC and the main challenge is that a lot of these chronic non-cancer pain patients are on opioids. We all know that, we all accept it. The problem is that for some of them, we don't know whether the problem is that their pain's undertreated or that they have some sort of use disorder, right? That's a diagnostic challenge, right? And that's something that can be addressed, I believe, must be addressed, and should be a core focus of PARC. So hopefully we'll get that. And this is just to illustrate what I was saying before. There's going to be a particular group. So if we're talking about 40 million people here, and we're talking maybe 4 million people here, there's still a huge number of people in this overlap area of the Venn diagram. And I feel that UCSF should have a specific focus on that patient group, in addition to the other work we're doing on opioid function and on substance use disorder in general. So there are a variety of pathways. I think I'm going to skip over this one and just get to this slide, which I always come back to. And this issue of opioid taper came back. This is a lovely study that was run by Beth Darnell down at Stanford, where they took a group of patients with chronic non-cancer pain who were on opioids. And they told the patients that there's evidence that opioids can actually worsen their pain, and that there's abuse potential and there's overdose potential with opioids. Would they like to try a taper, right? So this was about 120 patients that they got into the study, and they stayed in the study for at least 4 months while they tried to taper their opioids. And as far as I know, this is really the only published study where they looked at this carefully. And what they found was, oh, sure enough, if you look at the change in pain score of the patients in the taper group, a lot of them had significant decreases in their pain score. On average, they were able to taper down to half of their ongoing dose. But I would like to point out that there's a significant subset of individuals whose pain actually got worse when they were tapered, right? That's not surprising to anybody that's ever had to deal with pain patients, but it gets at this issue of, you know, should we take all patients off chronic, opioids? That it gets at this issue of whether there is long-term efficacy for opioids. And I would say this is probably the only and the best evidence that opioids are effective on a long-term basis. Because remember, these are all people who had been on chronic opioids before they entered the study, were followed for four months at least, and a bunch of them got worse, when their opioids were tapered, right? So one of the conclusions is, the opioids were helping them. Well, were they helping them because they had a use disorder, or were they helping them because they were actually getting an analgesic effect? Well, this study can't answer that question, but I would suggest that UCSF try to examine that question both at the preclinical and the clinical level. Some outstanding issues, things that came up today, and I think need to be emphasized is, how would you go about defining use disorder in someone that's got chronic pain? It's really very difficult, because if a physician is prescribing an opioid on a regular basis, a lot of the definition of use disorder goes away, right? Because part of it is you spend a lot of time trying to get the drug, right? The drug has an impact on your ability to function normally. You have cravings and symptoms when the drug is reduced. Well, sure, that's going to happen to everybody that's on long-term opioids, because dependence and tolerance are very common in this group of patients, right? So does the patient have a use disorder? I think it's possible to figure that out, but we need to do, right? So then going back to Stefan's, something that he raised in his talk, what patients benefit from opioid agonist medication? Why is it okay to give an addict, buprenorphine or methadone, but it's a bad thing to give it to a pain patient? That's something that never really made any sense to me. And it's something that we really need to think about. The other thing, that I think was alluded to by Alan and to a certain extent, Lawrence earlier, is, are opioids better for some causes of pain than for other causes of pain? I mean, I had this rule when I was practicing that I would never start a headache patient on an opioid, because medication overuse headache is such a common thing. And it never seemed to work on a long-term basis. On the other hand, if a patient had, say, neuropathic pain, for example, patients with postherpetic neuralgia or diabetic neuropathy, the opioids were often consistently effective over a long period of time without having to escalate. But that's all anecdotal. There really isn't much scientific evidence for that. All right, so this is addressed to the members of PARC, what I would like to see PARC do. First of all, we had an amazing talent here at UCSF in all areas relevant to the problem, from the crystal structure of the molecule to spiritual healing. We covered all the bases here. So if there's a solution, UCSF should be able to find it. And preclinical research, specifically, I'd like to see studies of pain in animals that are tolerant to opioids. And conversely, I'd like to see experiments on how do opioids work in the presence of chronic pain. You know, we don't tend to do chronic pain studies looking at pharmacology, but it's something that can be done. There are people that are in other institutions that are doing it. Big question that Ashish covered, and I think is still an open issue, is how targetable can we get for analgesia with opioid-like medications? Or are we going to need, for example, to use combinations of drugs to reduce side effects while getting synergy for the analgesia, so-called, combination therapy? I can say anecdotally, again, really anecdotally, and I think Stefan kind of agreed with me, is that in general, the patient with chronic pain, whether it's neuropathic or musculoskeletal, it's often the case that you're using a combination of drugs. It'll be a nonsteroidal, a gabapentinoid, an antidepressant, a serotonin non-selective reuptake inhibitor. So, but those sorts of things have not been done systematically. Mark, I want to emphasize again the urgent need to have a clinical facility that specializes in opioid use disorder patients with pain and in chronic, non-cancer pain patients with suspected substance use disorder, whether it's opioids, alcohol, or benzodiazepines, because all of them can be problematic. So for those of you who are still here, please, if you haven't yet, join PARC, reach out to your colleagues, check the website, try actively to contact the colleagues outside your own area of expertise. Don't retreat into your little ivory tower that's isolated from what everybody else is doing. Go beyond, take a chance, talk to people who are doing things outside your area of expertise. And if you have suggestions on how to make these retreats better, how to promote interaction, send an email to Mark Schumacher. And I assure you, he'll get back to you right away.
Bring him
Let
on.
me just interject for a second. Hopefully this posted. I did share the direct HTTP link in the Q&A for the survey now. So if you didn't get a chance to follow the QR code, please go into the Q&A and hopefully that posted. Sorry.
Okay.
Go ahead, Howard, finish up.
Well, I just have, my last point was stay safe, but realize that it's cocktail hour.
Mark, can I add one thing to a question that Paul Sue posted? I don't think anybody responded to it. And I have a specific reason for wanting to respond to it. What he's based, well, Paul, I don't know if you're still on and you want to read it. But he says, well, as a chronic pain provider at UCSF, I'm still weaning patients off opioids for chronic pain, since as summarized in the CDC guidelines, aside from the risk of overdose and other adverse side effects, there lacks solid evidence for the benefits of chronic, opioids in helping improve pain and quality of life. And then he goes on to talk about buprenorphine. Well, I happen to have chaired a large panel, and Howard knows about this, when the CDC guidelines came out. And there were patients sitting around the table with people from NIH and the CDC, VA, DOD, and the patients went completely ballistic because it's one thing to say there's no good evidence that the opioids are effective or what. Well, the fact is the CDC even admitted there was no good evidence for any of their guidelines. They have levels of confidence. They said you should only give opioids, 3 days of prescription. Any evidence? No. You should only, no. They had no evidence. This was a gut response to the opioid epidemic. And so I think we need to be really careful as I'm still not convinced. I mean, I know Jane Ballantyne very well, and I know plenty of people, and I also know plenty of patients who will tell you, I'm on this opioid. It helps me. I don't increase. I'm on the same damn dose for the last 10 years. And so I think we're talking prescription medicine where we can't sort of generalize and say, yes, they work for non-cancer pain, or no, they don't work. And so there's something about the individual patients. But I remember don't cite the CDC guidelines to me.
Yeah, they're back. They've backtracked already.
Oh, I didn't know that.
Yeah, the CDC.
Well, I can step in here. I have to say a few things. And from my own practice and what I've seen, and on the National Academy Committee, as long as many of you have been on these committees, but
you couldn't possibly have been on a committee longer than me. I'm far and away the oldest person here.
Yes, you win, Howard. You win.
Okay, I just wanted to get that out there.
And that's not my goal, actually. Believe me, it's not. Nor is it.
Anyway, I agree with Alan 1,000%. I just wanted to throw that.
Mark doesn't, so let's hear what he says.
But
Okay.
the critical point is that there is a dose-dependent increase in risk of overdose on the OMEs, daily OMEs, and that data is has been shown by different cohorts. So that to me is frightening, and that on top of the fact that we don't know which patients, where the risk versus benefit, where the benefit is really life-saving for those patients. They have a life or they don't, right? So this is the intersection that I talk about. And when you see me pushing back, it's because there's obviously dose-related risks here. And whether the physicians or the patients understand them, are willing to work together on them, is what needs to change in the culture of medicine, because currently we had unrestricted escalation without monitoring and without any discussion. And I think everyone agrees with that. And I would like to say that beyond, the foundational work we're doing here, that a big part of PARC will hopefully also be an extension in education, provider education and public education, and frankly, getting the resources to support that kind of outcomes research that would complement all the great basic science work. So I'm not so far off from all of this, but I just think that realistically, I've just seen so much disaster, with patients on the outpatient or the inpatient side. And we're totally failing exactly. This patient has pain and an opioid use disorder or a substance use disorder. I see these patients monthly. And unfortunately, some patients, are not well served by our current clinical system. They've gone out, been discharged, and died within a week. And so that, weighs heavily on me and probably other, clinical physicians that they're faced with this. So I fully support this direction, but we have to keep it in mind that ultimately there has to be a balance between the what kind of risk and where those cutoffs are. And it's from that data that I work from, and not necessarily about a cutoff for analgesia or quality of life. Thank you.
I think we should have a special group meeting on specifically that issue, because it's incredibly important. There's a lot of misunderstanding around about what the best way forward is.
Dorit, yeah?
Can I say something?
Please.
I have to kind of decided to jump in. I have chronic pain. I had the spine fusion surgery. I'm taking Vicodin. I never escalated the dose. It helps me to keep my pain in check. I'm always in pain, but it allows me to work and not to think about it all the time. You know, I said if I have more time, I would have actually written a letter to the editor of the New York Times about the stigma of people suffering from chronic pain that are taking opiates. It really, it's terrible. And I think that, us people that live with chronic pain, it allows us to function. And our voices need to be heard until we find something better. I heard Alan's talk and I said, I will be the first one to get the anti-NGF antibody treatment. And I talked about it actually with Howard a while back. So until we have something else, that's what keeps us going.
Mhm.
Anyways, I just had
Absolutely. Thanks for speaking up. And I do think that, and I didn't quite full out my introduction, but, and who's going to do this unless it's us? I mean, we need to step forward because no one else is stepping forward with this. And even on top of that, we have COVID, which is making things worse for everyone through the isolation, the disruptive pain care, clinical care pathways now. And as Lawrence pointed out, it's even worse demographically for Black patients in other ethnic groups. So, I mean, it'd be great if we had a vaccine for pain or for addiction or something like that. And so in some ways, COVID is decimating as it is, has to a degree a scientific understanding and approach, which doesn't really exist yet for pain and addiction together. I was just contemplating that. So I appreciate all your time and continued support for this effort. It's going to take some time. I'll just finish with what Howard mentioned is that amongst the thematic areas that PARC is trying to embrace and find leadership and such, I do think that we need to sort of either condense or expand a couple of these thematic areas to more directly approach this clinical area. I think that would be a very helpful. Yeah.
Good.
All right. Well, it's now 4:18 and it's been fantastic. Thanks you all. Alyssa, thank you again for also your support, and Howard and the rest of you. We'll see you again. Hopefully next Monday we have our next seminar speaker. Thank you so much.
Yep. Thanks, everyone.
All right. Cheers.
Bye.
Bye-bye. Thank you.
Great to see everybody. Really love this.
All right. Take care. Bye.
Bye-bye.